Hello, everyone. I'm Dr. Leslie Kernisan, board-certified geriatrician and the founder of the website betterhealthwhileaging.net. And this is the Better Health While Aging video podcast, where we discuss common health problems that affect people over age 60 and the best ways to prevent and manage those problems. We also often address common concerns and dilemmas that come up with aging parents and other older loved ones, like what to do if you're worried about falls or safety or memory or even the quality of an older person's healthcare. In today's episode, we are going to talk about a topic that is very important in geriatrics, which is the management of a heart condition called heart failure. Now, as this is one of the most common heart conditions in older adults, I think it can be really useful for older adults and their families to understand it better. So I'm very glad to be able to bring back one of my favorite cardiology experts who can explain the most important things to know about heart failure and treatment options today. My guest is Dr. Cara Pellegrini. She is a cardiologist specialized in electrophysiology and a professor at UCSF. Dr. Cara, thank you so much for being here today.
It's my pleasure, Dr. Leslie. Thank you so much for the invitation.
Okay, so Dr. Cara, I have come up with the questions that I get asked most often, but first I'm going to briefly present an overview of what I'm hoping we can cover today. So in this episode, we will be talking about, first of all, what is heart failure, the definition, what it means. If a health provider tells you that you have it or that your loved one has it, we're going to talk about what causes it, what are the signs and symptoms, how it gets diagnosed by health professionals, and then we're going to talk about how it's usually treated and managed, especially if people are older or frailer, which comes up in my line of work. And then finally, I'm going to ask Dr. Cara to talk a little bit about how heart failure relates to atrial fibrillation and other arrhythmias. That's an area of particular expertise for her. And we'll finish up with questions that she recommends you ask your health providers. So with that, let's just get started, Dr. Cara. What is heart failure? Why don't we start there?
Thank you. So I've always had a little bit of distaste for the term heart failure, though that is exactly what you'll hear this condition referenced as. And I want to just reassure any of our viewers that in the case of heart failure, there isn't a true failure of the heart, but more of a weakness of the squeeze function or a dysfunction of the relaxing of the heart. So in this diagram, you can see in the middle picture a normal heart, and the heart has four main chambers, and the heart's job is to be a pump. And the blood comes in the right side of the heart through the right upper chamber called the right atrium, goes to the bottom right chamber called the right ventricle, gets pumped to the lungs to get oxygen, and then comes back to the left side of the heart via the left atrium and then the left ventricle, which is the most muscular chamber in this pumping heart, that then squeezes that blood, newly oxygenated, to go to the rest of the body and provide that nice oxygen-rich blood to all the working muscles and organs of the body. When someone has heart failure or heart dysfunction, it comes in one of two main flavors, and sometimes they can co-occur. The first is what we call systolic dysfunction, and that's diagrammed in the picture on the left. And in that case, the left ventricle, instead of being a really strong pump, has gotten weaker to some degree. And oftentimes when the heart gets weaker, it can also dilate. And you'll note in this picture that the left ventricle is larger, the wall's a little bit thinner, and the strength of the contraction of that chamber has diminished. Another type of heart dysfunction is called diastolic dysfunction. In that case, the heart muscle may be thicker, as you see in this diagram, that the left ventricle might be thicker. But most importantly, it doesn't relax as well. So when the blood is being advanced into that chamber, it's a little bit more resistant to being able to fill with that blood and has to work harder to do its job and to pump the blood forward.
Yeah. So, yeah, thank you for that explanation. And I think it's so true. I mean, I think having gone to medical school, I kind of took this term for granted, heart failure, but you're right. It makes it sound so dramatic, like the heart is just pooping out and about to stop working. And as you pointed out, it's really, in most cases, a certain dysfunction. It's not working as well as it could. And specifically, that refers to its ability to pump blood to meet the needs of the body. I've heard you sort of say in the past that the heart is a pump. And then one of the other things that they teach us in medical school is that systole is like when the heart squeezes, right? And diastole is when the heart relaxes. And I guess during the squeeze is when it's making the big push, especially on the left side, to push the blood out to the body. And when it relaxes, that's when those bottom chambers can fill, right, with blood. And so you were saying that, there are kind of two main flavors of heart dysfunction, also known as heart failure, which is that it can be on the systolic side, meaning it's having trouble generating enough oomph outwards, often because that left side has gotten kind of maybe dilated, distended, weakened for various reasons, which you'll take us through. Or there's the diastolic type where I guess if it's thicker and it can't relax enough, it's sort of interesting that actually it's really important for your heart to be able to relax enough to properly fill. I don't think that, is something that I intuitively understood very well until I learned a lot more about heart failure. Now, what about the term that I feel like I was taught in medical school, probably you too, but I feel like it's fallen out of favor a little bit, congestive heart failure. Is that just no longer being used anymore?
Yeah. So where that term comes from is that when people have heart failure or heart dysfunction, the body cannot have enough blood at times. And when the kidneys, which filter the blood and help the body make urine and excrete some of the elements that aren't needed, when the kidneys don't get enough blood, they assume that your body has hemorrhaged and has lost blood. And their response is to hang on to more fluid, hang on to more salt. And the body starts to have more and more fluid, to be volemic, to have more and more fluid. And that can lead to what's called congestion or extra blood volume, extra swelling in the legs, extra swelling sometimes in the abdomen, more difficulty breathing because blood can be in the lungs as well. And so that's how that term congestive heart failure came to be, because we observe that these patients are congested with this extra blood volume that's part of a mechanism meant to maintain an equilibrium that's now doing the body a disservice.
Uh-huh.
You're right that these days that term has fallen a little bit out of favor, and that now we usually just use the term heart failure. I think that's partly a simplification, and also because not all patients with heart failure present with that congestive
Yeah,
component as
that
kind of the
extra
most predominant
fluid.
feature.
Mhm.
Um, Two other terms that you'll sometimes hear used that I think now would be a decent time to mention
Mhm.
are heart failure with a reduced ejection fraction. Sometimes a provider might call it HFrEF, or
Mhm.
heart failure with a preserved ejection fraction, or HFpEF. And
Mhm.
these are terms that if you search online or go to a doctor's appointment, you may hear mentioned. And they don't perfectly, but do mostly match to what we've described with systolic dysfunction and diastolic dysfunction,
Yeah.
where
Can you
HFrEF.
tell us very quickly what is the ejection fraction?
Yes. So the ejection fraction is the amount of blood that is in the left ventricle that exits the left ventricle successfully with one squeeze. And it's given as a percent. So the percent of the volume that exits the heart with that one beat. And normal is 55% or higher. You're never at 100%. 55, 60%, that's normal. And so with systolic dysfunction or HFrEF, that number can be decreased, can be 50% or 30% or 15%. And the amount to which that number is decreased corresponds to the severity of the systolic dysfunction. In HFpEF, the ejection fraction as calculated, and I should mention this is done often through an ultrasound called an echocardiogram, which takes a look at the heart function in real time. In diastolic dysfunction or HFpEF, the ejection fraction will calculate normal, but the patient may still have the signs and symptoms that we will talk about in a moment that correlate with heart failure. And so, though the ejection fraction is normal, there still is a lack of full efficiency of the heart function.
Okay, great. And then I guess one other thing that I sometimes think of when it comes to types of heart failure, and you've alluded to this earlier, is just the question of whether it's on the left side or the right side. I believe left-sided is much more common, right? But for some
Yeah.
people, it
So
is mostly in the right side.
yeah, absolutely, Dr. Leslie. So we usually are talking about left-sided heart dysfunction, and that is the more common thing. The left ventricle has to work so much harder to pump against the resistance of the blood in the arterial system of the body. It's a higher pressure that it has to pump against. So it's more likely to be noticeable if there's a decrease in that function. The right ventricle is a little more protected in that it's just pumping against the blood pressure in the lungs, which is lower. But it does happen that people can have right-sided heart dysfunction, either in conjunction with left-sided heart dysfunction or in isolation. So, for example, if someone has a stenosis or a tightening of one of the heart valves called the pulmonic valve, and that's the valve that you can see in the middle of the diagram here, that allows the blood to exit the right ventricle and go to the lungs. If that heart valve gets really tight, then the right ventricle has to pump against that fixed obstruction, and that is very exhausting. And over time, can lead to the right ventricle specifically and particularly developing dysfunction.
Mm-hmm.
That's just one example.
Yeah, yeah. Well, I want to talk more about causes of heart failure, and we should talk more about these valves. We'll talk about that in a moment, taking people through the fact that there are different valves and that they are relevant or can be relevant to heart failure. But first, really briefly, how common is heart dysfunction in general, and especially in older adults?
Yeah, it's very common actually. Heart failure or heart dysfunction is predominantly a disease of people who are older. It's pretty rare in people who are under 50 or 60 years old. And again, if you're lucky enough to live to be 80, more than 12% of people have some degree of heart dysfunction. Partly that's because over a lifetime, you have the opportunity to collect cumulative insults to the heart in the form of high blood pressure or periods of ischemia where part of the heart muscle doesn't get enough blood or other metabolic stresses. And so over time, these events accumulate and create heart dysfunction. But even outside of those things, there's a certain process, just as the normal part of aging, that involves heart stiffening and blood vessels stiffening, and kind of mimics the diastolic dysfunction that we talked about. It's interesting. It used to be thought that was a completely unavoidable pathway, and I think that that is at least partly true. But we have been able to observe a fair bit of variability among people, and to say nothing of among species, and understand that lifestyle factors, as well as some interplay of genetics, can definitely play a role. And by kind of making good lifestyle choices where possible, that we can delay or sometimes even reverse some of those quote unquote natural aging processes.
So exciting. Okay. Well, let's now talk about just, because you started getting into this, like what causes heart dysfunction? What are some of the, most common causes that we see when we identify heart failure in someone and start looking into what is the cause? So first of all, I've heard it said that it's kind of a clinical syndrome, right, of the heart not pumping, being able to pump effectively enough to meet the body's needs, and that there is usually one or more underlying causes, right? So it sounds like it would be reasonable if you're told you have some heart failure, some heart dysfunction. It would be reasonable to ask, oh, what do you think caused it, right?
Yeah, yeah.
Because that's a
It
way to
is
understand your health better.
that's exactly right.
Okay.
And it's important to ask that question of what do you think caused this? Because sometimes reversing, some of those factors that cause the heart failure can lead to recovery. So it is, I think, a question that's definitely worth asking and investigating.
Uh-huh.
Um, so some of the most common causes of heart failure, particularly heart failure in older adults, include high blood pressure over many years. if your heart is pumping against, a higher pressure, that can lead to either most commonly this diastolic dysfunction or HFpEF, but can also lead to systolic dysfunction or HFrEF. Additionally, ischemic insults, so partial obstruction of some of the blood vessels that feed the heart muscle, or a complete obstruction of one of the blood vessels that feed the heart muscle, called a heart attack, can be a cause of heart dysfunction as well.
Mm-hmm.
Additionally, there's a whole host of what we call cardiomyopathies, and these things can lead to heart failure or heart dysfunction. Within that group are things like toxins. So, alcohol in moderate or heavy amounts can create heart dysfunction. And I like to mention that one in particular because that one is notoriously reversible.
Mm.
So, if somebody does have heart dysfunction on the basis of heavy alcohol use over many years, oftentimes, if they're able to cut back or quit, we can see complete or at least partial recovery in the heart function.
Mm-hmm.
So it's worth noting that one.
Yeah, that's amazing.
Um, Additionally, among older adults, I think it's important to mention a condition called amyloidosis, where there's an abnormal protein that's being laid down and disrupting the architecture of the cardiac cells and muscle cells, and can lead to a decrease in the heart function in multiple ways. And that's something that there's actually been a lot of new treatments for in just the last couple years.
Mm-hmm.
And so we're thinking about that condition and looking forward and recognizing it a lot more often. Additionally, arrhythmias. So if the heart goes in a funny heart rhythm, particularly a very fast heart rhythm for a long period of time, or has a lot of premature beats, what we call premature ventricular contractions or PVCs, a high burden of these things can lead to heart dysfunction. And I like to mention those as well because, again, they can be very high likelihood of reversible etiologies. Along those same veins, if any of our viewers have a pacemaker and are having the bottom chamber of the heart paced a lot of the time, that too can lead to the heart function declining over time. And again, has a pretty good treatment solution. So, another thing worth considering. Important to mention one more thing, which is that sometimes these cardiomyopathies are what we call idiopathic. They happen to people for reasons that we can explain. So it is, not always possible to know, but oftentimes there can be some thoughts about why, in a particular person's case, it came up, and these thoughts can lead to a more personalized treatment plan.
Okay. And then also, while we're talking about causes, maybe we can come back to valves, right?
Oh,
So the heart has these four chambers, and there is a valve, a little sort of thing that opens and closes between the different chambers. So maybe you can take us through the key valves of the heart and how often is it what causes valve problems and how often is it a valve problem that is causing some heart failure?
yeah, that's a great point, and thank you for making sure we touch on this. So there's four main valves of the heart, two on the right side and two on the left side. We mentioned the pulmonic valve that opens and is the path for the blood to go from the right ventricle to the lungs. Also on the right side is the tricuspid valve, and that's the opening between the right upper chamber and lower chamber. On the left side of the heart, the mitral valve is the valve between the left upper chamber and lower chamber. And then just hidden and poking out there is the aortic valve. And that is the opening between the left ventricle and the aorta. And I want to highlight that one because I think, particularly for older adults, that's the one that comes up the most frequently. So the aortic valve is a pretty important one. And if a person develops what's called aortic stenosis, a tightening or calcification of that valve, that can cause heart dysfunction and a whole host of other symptoms, including chest pain and shortness of breath and dizziness. Basically, that valve, as I said, becomes more calcified. The calcium deposits on that valve, which allows it to not move as much, not create as much of an opening. And that too is something that we have better and safer treatment options to deal with. So is worth pointing out as a common reason for an older adult perhaps to newly develop heart failure, that would be worth specifically noting as the cause.
Yeah. I mean, one of the ways that I often think of it is with valves is that sometimes they have stenosis, which means they're stiff and they're not opening as easily. So that's more pressure for the chamber behind it and less blood getting through. And then the other thing they do is they leak, or often on the echocardiogram, that's called regurgitation. You know,
Mhm.
they're not throwing up, but they're kind of, they're supposed to close, at a certain point. And if that is leaky or floppy, blood can kind of go backward in the direction it shouldn't go, and that can put pressure on the chamber behind as well. And I don't know which is most common in older adults, but it sounds like you find aortic stenosis is a particularly common valve problem related to heart failure in older adults.
Yes, exactly. And there are other flavors, and the one other thing that we can mention is mitral regurgitation. So we
Mhm.
mentioned that the mitral valve is the one that's between the upper and lower chambers on
Mhm.
the left side. And
Mhm.
if you look at that picture on the left, where we have the very dilated chamber, so if you get more advanced systolic dysfunction and dilate that left ventricle, it can stretch the valve leaflets to the point that even when they're kind of fully extended, they don't touch anymore. There's just this constant kind of gap right in the middle. We call
Mhm.
that functional mitral regurgitation. There's nothing wrong with the leaflets. They've just gotten stretched apart with the chamber dilating such that they can't reach each other anymore. And then that just kind of snowballs and worsens
Right.
the whole process. And so that too is something that we have some new treatment options that are catheter based and not like an open heart surgery, where we, not to get too technical, but we go in and we put a little clip on those little two leaflets to kind of bring them a little closer together. And that's kind of a cool and an inventive idea, that again can really improve people's symptoms.
Okay. So to come back to causes, so again, if you are told that you're dealing with some heart failure or heart dysfunction, you can ask what are underlying causes. And you said some common ones are high blood pressure, coronary heart disease. So, problems with your coronary arteries, which can give you a heart attack. Or maybe also, even if people haven't gotten to the point of having a heart attack, just having some coronary blockages can affect the heart and cause heart failure. There can be cardiomyopathies, problems that affect the heart muscle. That can be alcohol, or it can be deposition of abnormal proteins or other toxins. And then there is valve disease as well that people can get. And it sounds like those are the most common ones that we see in older adults.
Yeah, I think the one other thing, Dr. Leslie, that I'd like to mention is diabetes.
Mm.
And I generally don't think of diabetes directly causing the heart failure, but more kind of going along with a lot of the other things we talked about. So people who have diabetes are much more likely to have heart artery blockages, are more likely to have high blood pressure. And so that's another just kind of very common condition that co-occurs with
Mhm.
heart failure.
Yeah.
And controlling diabetes, keeping the blood sugar in the more optimal range, also has, positive effects
Mhm.
from heart function.
Yeah. Yeah. And well, a little later we'll talk about kind of prognosis and how heart failure progresses because in general, like many conditions in medicine, it's kind of a spectrum, right? People can have just a little bit of it, or it can be quite worse. And especially if you don't care for it optimally over years, it can easily get worse over time. But we'll talk more about that in a second. But first, just coming back to, we've talked, about the causes and what it means, but what are the signs and symptoms? What are the things that people actually experience related to heart failure, to heart dysfunction?
Yeah. I would say the most common things that people experience are fatigue and shortness of breath. The shortness of breath mm, often can be just with exertion. So maybe, not feeling short winded just sitting or just talking, but maybe at the more extreme, climbing a flight of stairs or walking up a hill. And if there is progression of the disease, then it can be that less and less activity or less and less extreme exertion can create shortness of breath. If a person starts to retain fluid, like we were talking about earlier, they might also feel short of breath when they're laying flat in bed, because all that blood flow can kind of be in the lungs, and they may find that sitting more upright relieves some of their shortness of breath, and that would be another very classic presentation for heart failure. There are other symptoms, such as swelling in the legs. So noticing extra fluid in the legs may be a symptom of heart failure. And with that, rapid weight gain. So not just gaining fat, a pound here or 2 pounds there, but gaining, multiple pounds within 24 hours would be a sign that maybe this is in part fluid retention.
Mm-hmm. Especially
People can have
after a salty meal.
exactly, yeah.
Mm-hmm.
And people can have other symptoms too. Sometimes some of these people feel, chest pain, as again, there's overlap with heart artery blockages. Sometimes people can feel lightheaded. Sometimes people, especially with more advanced heart failure, can be losing weight. So a range. But again, the
Mm-hmm.
two most common things are fatigue and shortness of breath.
Mm-hmm. And sometimes their blood pressure can be relatively low too, right? Because the heart is having a lot of difficulty pumping. But other times their blood pressure, I think, can be still high, right?
Yeah, that's true. We
Yeah.
can see a range depending on what type of heart failure they have and how advanced it is.
Mm-hmm. Okay. So we talked about, the most common symptoms being shortness of breath, especially with exertion, fatigue, sometimes leg swelling. But of course, you and I know that there are lots of other medical conditions that can cause those symptoms too. That can be part of the challenge of heart failure. So, can we just briefly touch on what are some of the other conditions that also have these symptoms and that have to be considered, when
Yeah.
somebody has these symptoms?
Yeah. So sometimes people can have other things wrong with their heart. So they can have a heart rhythm problem, they can have a primary valve problem, they can still have a normal squeeze to the heart, but have a heart artery blockage in isolation thus far. And that can, similarly present with shortness of breath on exertion. The swelling in the legs can be caused by a multitude of different things. So things can, relatively benign, such as poor venous return, what we
Yeah.
call kind of the venous stasis, or
Probably
just
the most common cause of swelling
yeah,
in the
yeah,
legs of
or just
older adults. So, if you've noticed that, don't panic yet.
exactly,
Right?
exactly,
Okay. Uh huh.
yeah.
Yeah.
So just in that case, the blood vessels are just getting, a little weaker, the veins, and the blood's a little bit leakier. And so there can be swelling in the legs, but that doesn't necessarily mean you have heart dysfunction. More rarely can be kidney problems or liver problems, again, causing the body to retain fluid. Sometimes thyroid or other metabolic processes can present with a lot of these things, such as fluid retention or fatigue.
And then, of
Obviously, weight
course,
loss brings up cancer
right.
or other things.
Yeah.
And lastly, I'll just say lung processes similarly can lead to fatigue and shortness of breath. And there's a whole host
Mm-hmm.
within that as well.
Yeah, often I feel like when people come in with some shortness of breath, we're partly thinking, is it the heart? Is it the lungs? Or it could be both, of course, because sometimes people have risk factors or conditions that affect both. So it can take a little work to tease out. And so if you have noticed these classic signs of heart failure, it's important to keep in mind that there are several other conditions affecting the heart, the lungs, other parts of the body that could cause similar symptoms. And you don't want to diagnose yourself. You really want to get evaluated by a health professional. So let's not talk about what that evaluation looks like. How is heart failure usually diagnosed?
Great question, Dr. Leslie. So, like everything else, your provider will generally start by just asking you some questions, taking a little bit of a history of what symptoms you've been experiencing and what other health problems you've had in the past.
How long
You
you've had them? What brings them on?
all of that. And it
Mhm.
can be an extensive list of questions, what
Mhm.
medications you take, what habits you have, have you smoked, do you drink, all of these sorts of things. And then you can generally expect that the next step will be to do what's called a physical exam. And they'll do some things that are perhaps a little weird. They might stare at your neck in here And in that case, what we're looking at is the neck vein that brings blood back from the head, called the jugular vein, has a pulsation here that we can appreciate in the neck. And when you're hanging on to lots of fluid, the where that pulsation is rises up the neck like a gas gauge in a car. And so by assessing that, we can get a sense of if your whole body is retaining fluid or if it's just the swelling in the legs. That's, a more benign prognosis, as we were talking about a few moments ago. They'll listen to your lungs as well and check your legs and your heart and all of that. Some other very common things that will likely be done include an ECG. That's an electrocardiogram where we put stickers on the chest and monitor for a few seconds the electrical activity in the heart to look and see if if you're in a normal heart rhythm. And we can also get some other information, such as some sense about chamber thickness and things like that. I mentioned earlier something called an echocardiogram or ultrasound of the heart, and that's very commonly done if heart failure is a diagnosis under consideration. That's a pretty painless test where you're in a dark room and an ultrasonographer will use a probe that they put a little gel and put that on your chest in different positions. And then on a TV screen, you can see the heart beating, and they'll take a whole bunch of pictures and then make measurements and analyze that.
And that was
Well,
very useful because that's when they can see how well your
yeah,
valves are working. They can see whether you have like dilation of the heart or not. And I think that's also where they make an estimate of that ejection fraction, right?
exactly, all of those
Mhm.
things. So we get
Mhm.
a sense of the size, the function, the morphology of the various chambers of the heart. Take a look at all the heart valves. Take a look if there's fluid around the heart or other things that could be contributing. It's a very common and useful test.
Uh-huh.
There are other ways to look at the heart that, in more specific circumstances, might be encountered, such as an MRI, but I would say that's a less everyday occurrence.
Mhm.
Um, if your doctor thinks that heart artery blockages might be at play, they might refer you for a stress test where you either walk on a treadmill or they give you a medication that assesses if there might be heart artery blockages. And they might even do what's called a heart catheterization, where they put an IV often in the wrist, but sometimes in the artery in the leg, and go up into the heart and inject dye directly as they take pictures to look and see if there's heart artery blockages.
Okay.
And then they'll very likely draw send you for some labs to draw some basic tests to see how the kidneys are doing, if a hormone called BNP or pro NTP NT-pro BNP is elevated, which again is another way of assessing wall stress in the heart and how much fluid the body's retaining.
Mhm. And we also, I just realized we forgot to mention anemia for conditions that make people, short of breath with exertion and tired, but we'll also make sure you're not anemic, and check on electrolytes. So is heart failure something that generally can be diagnosed by primary care providers, emergency department, or how much specialty care is usually required?
Yeah, that's a great question. And I would say it depends. I think definitely if someone is in more advanced or florid heart failure where they're retaining lots of fluid and it becomes kind of, very obvious, that might be a condition that would be evident even with minimal testing with a good physical exam and history. I think, in a more mild or moderate case, I think a provider might have a very good inclination that this seems like the most likely diagnosis, but then would do a confirmatory test like that echocardiogram we were talking about to kind of really solidify that suspicion.
Yeah. So to kind of recap, if you've had symptoms that seem like they might be heart failure, you definitely want to get medically evaluated. They should ask you questions about your symptoms, how long you've had them, what's bringing them on. Do a physical exam. I think it's mostly the cardiologists that are going to be looking here, but I would say the average doctor will probably listen to your heart, your lungs, see if you're having leg swelling. They do often do a chest x-ray. That's partly to take a look at what's happening in the lungs too. a EKG to look at your heart rhythm, make sure you don't have an abnormal rhythm, one of those arrhythmias. I believe they can also sometimes see if you've had a past heart attack on
Mhm.
there, and then especially getting referred for an echocardiogram so they can get a better look. Now, do people usually need immediate treatment or not for heart failure?
Yeah. So again, it depends. I think oftentimes if it's kind of just beginning to be diagnosed, that's not a situation where someone, say, needs to be admitted to the hospital for urgent medical treatment. It's something that will kind of evolve over, weeks and perhaps months. And so I would say, is not necessarily an emergency. That said, there are instances where the first time someone comes to medical care is when they're really feeling bad and they are in what we call florid heart failure, retaining lots of fluid, and they'll, present to the emergency room, and the docs there will say, "Gosh, you're, very sick. You need, best thing would be to be admitted to the hospital."
Mm-hmm.
So, it sort of it depends.
Yeah, yeah. And I think of this as a kind of chronic ongoing condition that can have, exacerbations or, sometimes like flare ups where suddenly it gets pretty bad. People have really bad symptoms and are feeling lousy. And then, in the hospital, they can really keep a closer eye and administer medications under supervision more quickly to try to help the heart feel better. Also, as part of that initial evaluation, I forgot to mention earlier, labs to check at least on the basics. So since we've talked about how sometimes heart failure is not so bad, sometimes it's worse, can you just speak briefly, because I have, people tell me about someone who has heart failure and ask me questions about it, and often I want to know, well, how bad are we talking? So can you just speak to what's the most common way we think of, stages or types or severity?
Yeah. So most commonly, we'll think about what level of physical activity might bring on symptoms. So, if someone's at the point where they're completely asymptomatic, but they have some signs that maybe the heart's not completely healthy, like on that echocardiogram, that would be a more early stage, like a stage one heart failure. If they're having symptoms with just very significant physical activity, so they can walk all they want on flat ground, but as soon as they start walking up a hill, they get short winded. We would call that, you might hear New York Heart Association class 2 type heart failure, a more mild type of symptomatology. And then if someone has symptoms with even just mild physical activity like showering or, walking to their mailbox, then we would call that a New York Heart Association class 3 type symptoms. And then finally, if somebody's having symptoms even at rest or to the point that they need to be admitted to the hospital for more advanced medical therapies, then that would be the most advanced or New York Heart Association class 4. Lastly, I would just say that there's been a real shift in cardiology to thinking more and more about prevention. So sometimes we'll even talk about a stage 0, and that's when people have some of the conditions we talked about, like high blood pressure or diabetes. And so far, their heart function looks good, but we know that they have these risk factors for developing heart dysfunction. And so we really want to just emphasize that just because they don't have heart dysfunction yet doesn't mean that we think these conditions are benign. And so now there's this term of heart failure stage 0, where you have, some of these preconditions, and it's meant to encourage more aggressive treatment of those things.
Yeah. And if I remember right, especially if people are in those early stages, 1 and 2, they can often stay there for years and years, especially if they're otherwise getting good care to
That's
protect
true.
the heart and support the heart, right? And that
That's
it
true.
often takes
And
years for people to get to that very more advanced stage.
yeah, so with regard to prognosis, it depends on what the contributors to the heart dysfunction are. And sometimes people can not only plateau, but can actually have positive improvement, particularly if they have, again, like something like alcohol or a PVC induced cardiomyopathy, something that we can reverse. We can see the heart function improve to the point that they, become completely asymptomatic and go on for many, many years. And then you're right that over time there can be progression, and it can come in the form of these kind of fits and starts, where things get really bad and then get a little better, but then get bad again. And I will say that the prognosis of heart failure in the last decade has greatly improved, and people are living for many more years. Just having that label, that condition, but still having many productive years of life.
Yeah, yeah. So I think it's important to emphasize that this is an important condition, can be very serious, and is also something that people can live with for years and years, especially if they're taking good care of themselves and getting good care from the healthcare system. And if the underlying causes have been identified and we've really tried to reverse those or manage those as best we can. So people do die of heart failure. And we can talk a little bit more about that at the end. But I would say a lot of older adults that I see have, one of the earlier stages, and it is something to manage. And if they have an exacerbation, it can land them in the hospital. And it's just one of many things often going on. And then there are some people who have much more significant heart failure too. Now, maybe we can talk now about how do we treat it and manage it, so that we can help people stay the best they can be for as long as possible, or maybe even reverse it. And I know that this is a topic where in cardiology you can go, talk for hours and hours about all the details, but maybe at a very high level, we can just talk about the key pillars of heart failure treatment and management.
Great. Yeah, you're right. I could drone on for quite a while. So, but in broad strokes for starters, and then we'll dive deeper as you see fit. First would be reversing contributing causes as much as possible. Second would be managing underlying conditions that might not be fully reversible, but at least managing them, such as controlling blood pressure, controlling blood sugar,
Fixing the
um,
valve.
yeah, fixing a valve, being, physically active. These things are super important. Second category would be diet. So specifically for people with heart failure, when it gets to that more congestive type picture, we'll talk about decreasing salt intake and decreasing actually even water intake. And so that's a very specific component for some people. And then broadly, medications. And these days, for people who have systolic dysfunction or have HFrEF, there's 4 classes of medications that we can dive more into, but generally 4 different medications at a minimum that people take, perhaps with some others to manage symptoms too. For people with diastolic dysfunction, there's usually about 3 classes of medications that are recommended, plus or minus, again, a diuretic, a pill to try and help flush out some of that extra fluid. And then beyond medications, for some people, the management might also include procedures, such as implantation of a cardiac defibrillator, if the heart function is severe enough. And I can talk more about that too, if you're interested. And and then there's some other procedures that come into play, particularly with the very more advanced stages of heart failure. And then lastly, I just want to make a shout out for cardiac rehab. So specifically monitored exercise program, and that can really be helpful in helping manage people's symptoms in heart failure too.
Okay. So it sounds like what you said is, definitely looking into underlying causes, contributors. Are there any that can be reversed or treated? And then for almost everybody, a sort of better lifestyle, quitting smoking if you're smoking, being careful about alcohol, exercising regularly. Certain people might benefit from a special supervised cardiac rehabilitation program. For many people, monitoring their salt intake, but maybe not everybody. And for some people, monitoring their water intake, but maybe not everybody. So that sounds like it's really important to clarify with your health provider whether that would be suitable for your type of heart failure, because it's not going to be necessarily the right thing for all types. And then you said medication. So in most cases, medications are highly beneficial, right? So maybe
Yeah.
we can just briefly go over the common classes for systolic dysfunction and for diastolic dysfunction.
Yeah. So these medications have actually been very extensively studied in kind of our highest level of research, which is called randomized control trials, where we really compare equivalent people that are randomly assigned to either get the treatment or not. And so we feel very, very confident about these treatments that we offer in heart failure. Not only do these treatments improve quality of life, but many times they have been shown to extend life, so decrease mortality, both of which are very important. And so the first class of medication that frequently is used is called a beta blocker. And that's a medication that slows the heart rate down a little bit. And in so doing, decreases some of the work of the heart and makes it a little easier for a sick heart to function most optimally. The second type of medication is something that relaxes the blood vessels a little bit. And there's actually three different medication classes within that. And so you'll be prescribed hopefully one of those three things. Briefly, the newest kid on the block is called an ARNI, which is a combination medication, or an ACE inhibitor, or something called an ARB or an ARB. But these are medicines that basically help the blood vessels relax a little bit and influence some of the hormones in the body that have to do with salt and water retention.
What is
The third,
ARNI a combination of?
it's a combination of sacubitril and valsartan. Valsartan is one of the ARBs,
Okay.
and then this other medication called sacubitril. And so this is one of our several new kids on the block in the last 5 to 8 years or so.
Okay.
That's been shown to be even better than some of the
Okay.
previously available options.
Okay. All right.
One, yeah,
Okay. And so we've talked about beta blockers, we've talked about medications that help relax blood vessels. The next category for systolic
yeah. The
dysfunction.
next category is something called an MRA, or mineralocorticoid antagonist, and
Okay.
another mouthful.
Mhm.
And so those drugs are gentle diuretics. They kind of help get rid of some of the extra fluid, but they also help balance the electrolytes. Whereas many of the drugs that we give for heart failure make people lose potassium, these drugs actually help boost the potassium. So it kind of helps balance things out a little bit. And they
Mhm.
have a little bit again of a role in our hormonal management. And
Mhm.
then the fourth category is the SGLT2 inhibitors. And so I'm sorry, these drugs, I don't make up these names.
All right.
Um, and so that's a medication that can actually be used for people who have diabetes
Mhm.
and a normal heart, or for people with heart dysfunction and no diabetes, or for both.
Mhm.
It manages blood sugar a little bit, but seems to have beneficial effects on the heart directly. And so those four classes of medications are the ones that have been most studied for improvement of symptoms and life expectancy for people with systolic dysfunction.
And then for systolic dysfunction, many people will also need to take a diuretic, also known as a water pill, right?
Correct. So
Mhm.
then there are several other medicines that aren't those standard four pillars. So one is the diuretic, and that's a very common medication. And there's a few choices there too, but that helps people pee out some of that extra fluid, and can be taken, once or several times a day. Sometimes people have heart artery blockages, and so they might be on other medicines for that, like a statin drug to lower cholesterol, or aspirin, or a medication to help minimize chest pain, and then other medicines to control blood sugar or high blood pressure, and lots of other possibilities. But I would
Lots
say
of other possibilities.
those are some of the mainstays.
Okay, okay. And then for people who have just diastolic dysfunction, which you said is fairly common in older adults, what are the key classes of medications that we know help with that?
Yeah. So as of like 10, about 10 years ago, we would say none or maybe one. And just in the last few years, some of those same drugs that I mentioned for systolic dysfunction that have been kind of new have been seen to be also beneficial with diastolic dysfunction, which is kind of exciting. So I would say the three main classes would be the ARNI that I mentioned. That one that relaxes blood vessels
Okay.
is helpful in diastolic dysfunction too. The MRA, or mineralocorticoid antagonist, that medication was one of the first to be found to be helpful in diastolic dysfunction. And then that SGLT2 inhibitor medication
The
has
diabetes
also
medicine.
been, has also been shown to be beneficial in diastolic dysfunction. I
Mm-hmm.
will say, since many of these people have high blood pressure as a major component of their disease process, they may be on one or two or more other medicines to help lower blood pressure, and that will have a significant impact on heart function for them as well.
Mm-hmm. Yeah. And I often tell families that, it's really important to find out if if the heart failure is causing symptoms, because heart failure can be such a quality of life issue, right? That when people have symptoms, they're tired, they're not getting up and moving around, because there are other chronic conditions people have where they're often not feeling anything. And but that this is a condition where often people are feeling something, and getting the right medication regimen and the right changes can really help people feel better within days or weeks, and makes a very immediate improvement in quality of life. So it's great that we've found these medications that help people so much. And it sounds like they also help with the longer term of heart failure. They keep it from progressing, and people are living, longer and better as well.
Yeah. Yeah, all of that's true, and yeah, it's not unusual that I'll have someone come in and say, "Gosh, I thought I was just getting older," and we find that that this isn't just within the normal purview of aging, that that they actually have some conditions, and it can actually be quite a relief finding and making a diagnosis, because then we can start thinking about, well, how can we improve, how can we make things better.
Right. Yeah. Yeah. So important to not attribute fatigue to aging. It does sometimes get waved off by that, by sometimes the older person themselves, sometimes by family, sometimes, I hate to say it, by health providers. And it's a shame, because it could be a condition that we could actually treat. So another thing that I often think about for heart failure treatment and management is that, I remember when we were in training that there was like often a significant component for people to do on their own of monitoring themselves. Can you talk a little bit about the self-management that is often recommended for people who have heart failure?
Yeah. So, especially for people who've had a history of retaining extra fluid, we'll suggest that people weigh themselves every day and look for changes in weight of more than a pound. So, 2, 3 pound changes in a day, especially if that goes on for more than a day, nipping that in the bud, increasing the water pill dose, decreasing salt and fluid, and trying to kind of get back to that kind of homeostasis, that kind of stable point, can avoid heart failure hospitalizations. So that's a really important point. Depending on the patient, monitoring blood pressure might be another piece of this. A lot of these medications that I mentioned can lower blood pressure, but in the service of improving the heart function and kind of making things more stable in the long term. But it can be helpful while we're just kind of getting things up and titrating these medications to the right level. We may ask people to monitor their blood pressure, as well as to monitor their symptoms. So noticing if you're starting to have a decline, starting to have more trouble doing things that a week or a month ago you could easily do, would be something that would prompt solicitation of medical attention.
Yeah, yeah. Because it sounds like part of it for heart failure, especially if you've had these exacerbations in the past, is to be paying attention, so you notice when you start to tip into more dysfunction, and you get help before it gets really bad.
Yeah, it once it gets really bad, sometimes you improve, but maybe not all the way back to where you were. There can be some irreversible components, and so we really try to not let it get to that point.
Mhm.
To notice small perturbations and kind of bring it back
Yeah.
um, as much as possible. And again, that level of diligence may not be needed for everyone who carries a diagnosis of heart failure. But can be something that we ask of
Mhm.
people with more significant disease.
Right. And so something potentially to talk to your health provider about, what should I be watching for at home? What kind of, monitoring do you recommend that I do? Could be something. Okay. And so when people are particularly old or frail, anything to keep in mind when it comes to the treatment and management of heart failure?
Yeah. So absolutely. I would say older adults are more likely to have the diastolic dysfunction, though not exclusively, and often can be more sensitive to medications. and more sensitive to blood pressure lowering effects. And so trying to think about which medications are helpful and at what doses are they tolerable and where kind of the risk benefit of some treatment might be is something that I try and think about with older adults. So kind of being honest and upfront, if you're experiencing more instability, if you're having falls, if you're having, low blood pressure readings, we may need to make some adjustments. I think that sometimes older adults have to do more advocating for themselves. We talked about that some practitioners can wave off symptoms as normal aging, or people themselves can. And so I would encourage any of our viewers who are older or have a loved one that might have this condition, that we should still be thinking about, what are contributing factors in older people. We talked about some things like aortic stenosis that can be very common in older adults and very treatable. And so, making sure that the due diligence of getting the appropriate testing and not just blowing things off, I think is important for older adults. On the flip side, we have a lot of treatments that we can offer, and we didn't even get to some of the procedural-based treatments for heart failure yet.
Uh-huh.
And thinking about, what a person's goals of care are, is something that does come up for older adults and everyone. And not getting swept away by the enthusiasm of one's provider for, A through Z, being
Uh-huh.
clear about, what one's goals are, I think are important.
Uh-huh.
Understanding that even if one doesn't want to, be a vegetable, as many of my patients tell me, that doesn't necessarily mean that you don't want any treatments, just worth, thinking through these things clearly, not
Uh-huh.
taking shortcuts.
Right, right. Yeah. So maybe now we can just briefly touch on some of the procedures and devices that are sometimes used. Now, my understanding is that these are more commonly used for the more advanced stages of heart dysfunction, but maybe tell us about what are some procedures that people might end up considering and when.
Yeah. So some things that I'd like to touch on are some things that relate to the arrhythmia EP involvement in heart failure. So, for example, there is a device called a biventricular pacemaker that helps coordinate the heartbeat for someone who has systolic dysfunction with an ejection fraction less than 35% and has on their EKG a more wide, what we call QRS interval. And that just means that it's taking longer for the electrical system to transmit the electrical signal to all the parts of the heart at the same time. And I bring up the biventricular pacemaker first because it's one of my favorite devices, as not only does it help people live longer, it really can make a big impact on how people feel. And
Mm.
so I think even for people who say, look, I'm older, I'm not looking to live forever, but I want to feel as good as I can feel, this is a device that, that I think has a place even for people in their 80s or 70s. And I mean, I think I've even done it for someone in their early 90s as well.
Mhm.
And so I see it as a quality of life thing, not only a quantity.
Is it a pretty easy procedure to tolerate, putting it in, like a same day kind of thing?
Yeah. So people are often able to go home from the hospital same day. It is a small incision up by the shoulder. So again, we're not cutting and going into the heart directly. It's all done through this small incision up here. There is some discomfort, but I would say most people manage with Tylenol or equivalent, so not big narcotic type doses. And after a few weeks, people can get back to their usual physical activity. So I think that's something, worth considering if you meet, certain specific criteria.
Mhm.
Another device we sometimes put in either together with that in a combined way or separately is something called an implantable defibrillator. And that's a device that's more purely focused on life extension. So we know that some people that have heart dysfunction are at higher risk of having funny, life-threatening heart rhythms from the bottom chamber. And this device sits back and watches the heart's rhythm all the time. And if there is some evidence of that life-threatening heart rhythm, it will try and pace the heart out of that. And if that fails, it will shock the heart and potentially be a life-saving measure. And again, that's something only considered generally for people who either have significant left ventricular dysfunction, an EF less than 35%, or people who've had one of these life-threatening arrhythmias already happen to them.
Yeah. And so and we were talking, you mentioned goals of care before. And so, I think of goals of care very broadly as, often in medicine, we have the goal of helping people live as long as possible, the goal of helping people feel the best they can in the moment in the shorter term. And then the goal in geriatrics we think about of helping people maintain their function, their ability to do things, walking, other activities that might be important to them. And so you were saying that the biventricular pacemaker is great because it really helps with that goal of quality of life and how people are feeling, which will also help with function. Whereas an implantable defibrillator is really something that is there to help extend your life. Because if you have one of these events that could end your life, it could shock you and help you continue. And that there are times in people's lives where they want that. They would like to live as long as possible. And I certainly have some people, who eventually reach a point where they're like, well, this is okay, but when, I'm ready to go when my time comes. And so in that case, that kind of implantable defibrillator might not be a great fit with that type of goal of care. And so I wanted to share that as an example of how we are thinking about goals of care as we try to assist families in selecting among options, especially in the, very later years of life.
Yeah, yeah. I think that's a really good point. And I think, we may now or at some point touch on, you know, sometimes people do die of heart failure.
Yeah.
And one of the ways that that can happen is what we call sudden death. And that in some ways that can be one of the easiest, most merciful ways to go. And so I definitely have some people who choose to not have a defibrillator, or maybe 10 years ago it made sense, but now, they want it disabled, so that there is that potential, way of dying suddenly, and that's not the worst way to go.
Mm-hmm. Yeah,
Yeah.
and so maybe we can touch on briefly. So, how do people die of heart failure? So many people will live with it for a while and die of something else, but some people do die of their heart failure. So you just sort of said that heart failure, especially as it gets quite bad, puts people at risk for this sudden arrhythmia that can cause, essentially a sudden cardiac death. I think what it looks like is people kind of collapse, right? And if they're not shocked or resuscitated, they could die. What are the other ways that people die of heart failure?
Yeah. So I would say 40% or more of people who have heart failure might die of something else. So just because you have a diagnosis of heart failure doesn't mean that will be the condition that ultimately leads to death. And then the majority, but not all of the rest of those people, will likely die of something heart related. It may be that sudden cardiac death that we talked about. For some people, it will be more in the form of a heart attack. So having, the chest pain and something more or less dramatic in that regard. And then for some people, the pump just gets weaker and weaker, and they get, less able to do things, and maybe start to see their weight kind of go down, and get to the point of kind of spending more time at home or even in bed, and then kind of, pass away from there.
And they can get hospice at a certain point too. Once heart failure
Exactly.
is advanced enough, or if you don't qualify for hospice, there are particular eligibility criteria for hospice. Sometimes it's possible to get other palliative care services to help you with the symptoms and be as comfortable as possible, even as you deal with like quite significant advanced heart failure symptoms.
Yeah, that's true.
So, okay. All right. Well, this has been so helpful, Dr. Cara. Thank you so much for explaining heart failure to us today. Why don't we maybe just to finish, just like review the things that are most important questions to ask of a provider if you have heart failure.
Yeah. I think the important questions are, why do you think this might have happened? And related to that, are there any specific things that we can do that relate to why this has happened to me, that would be more personalized? And I just can't resist making a quick side note on that since we didn't touch on it yet, that atrial fibrillation is another type of heart rhythm coming from the upper chamber of the heart. You and I have spoken about that a little bit before.
We have a wonderful video about it. We will post a link in the related notes.
Yeah. And so treating atrial fibrillation is yet another example of where when we treat a related condition, we improve the function of the heart. Moving on from there, what are the best treatment options for my specific condition? And then I think it's really helpful just to have a dialogue of exchange about, what are my goals and how do the things that you're thinking about with regard to treatment relate to those goals?
Yeah. And maybe also when you hear the term heart failure, you could also ask them to clarify maybe what type, whether it seems to be mostly the systolic type versus the diastolic type, and maybe whether they think your heart is having some difficulty with the strength of the squeeze. You can also potentially ask them to review your echocardiogram results with you and explain the findings to you as well, right?
Yeah, absolutely. I think knowledge is power, and I think a good health provider will want to make you as informed and understand your condition, and I think that's a great way to be able to partner and think about what to do.
Yeah. And I want to, close on what you said at the very beginning, which is that heart failure makes it sound like it's so bad and not working, but in fact, it's a common chronic condition that in many people starts off, relatively mild, or even if it's bad, it can get much better if you get the right care and treatment, especially understanding the underlying causes, managing any lifestyle factors that are contributing to it. Dr. Cara took us through medications are often extremely helpful. So sometimes we prescribe too many medications in medicine, but this is a case where we have lots of good evidence. It can be very, very helpful. So if medications are recommended to you, seriously consider them. And thinking about goals and learning to monitor your symptoms at home. I think those are some of the key things we talked about, right, Dr. Cara?
Yeah. I think like anything in medicine, the more that we can work in partnership where, patients are thinking about what is my role here? What things can I be doing to help manage my condition? And then the provider, can provide information and help the patient kind of work through decision making about treatment options and offer that expertise. I just again like to underscore that this isn't an immediate death sentence. This is a condition that people can live with often for many years, and that there is heterogeneity within the term. So it's useful to understand some of these complexities that we've spent time talking about, and that there really is space for improvement and how one manages one health in this case definitely can impact impact outcomes.
Yeah, can impact how you feel, how you're able to participate in your life, because your heart is there to pump your blood so you can be participating in life and taking the right steps. It does get better. That is what we have learned
Well said.
through the work of cardiologists. So thank you so much again, Dr. Cara. And with that, I'm going to wrap up this episode of Better Health While Aging.
Thank you, Dr. Leslie. Have a great day.
So with that, thank you so very much for watching. And if you found this video podcast helpful, if you're here on YouTube, please go ahead and subscribe, as it does help more people find the channel. And if you're someone, again, who is trying to figure out how to help an aging parent, I have a special interest in supporting people like you. So I've created a variety of helping older parents resources and trainings. And I also have a book, When Your Aging Parent Needs Help. So if you'd like to get more useful information on how to care for your aging parents, including the free trainings, please visit betterhealthwhileaging.net/helping-older-parents. And then last but not least, if you've been listening to the audio version of this episode on the podcast feed, please come and take a look at the video if you get a chance. You'll see my key points displayed on the screen. So thank you once again, and I look forward to seeing you all again on a future episode of the Better Health While Aging video podcast.